So good afternoon, everyone. Today I'll be taking a short session on tumor markers. I'm Dr. Nandita Pradeep and I'm a consultant pathologist from Kerala. So what are tumor markers basically? So as the word says, tumor markers are markers which indicate cancer. So they are biomolecules which are associated with cancer. They can be found in blood, urine or tissues. And how do they become useful to us? Because they can be used in diagnosis. Even though the use is limited in diagnostic purpose, it can be used for monitoring therapy and for detecting recurrence. So we classify these biomolecules based on their properties into 5 different categories. So this is how we classify tumor markers. They can be either hormones, oncofetal antigens, lineage-specific proteins, mucins and glycoproteins, cell-free DNA markers. Hormonal tumor markers are hormones which are increased as a result of a tumor or in association with a tumor. And examples include beta HCG, which is seen in association with trophoblastic tumors or non-seminomatous testicular tumors. Then calcitonin, which is another hormone seen elevated in case of medullary thyroid carcinoma. Then catecholamines, which are usually seen associated with pheochromocytoma, that's adrenal tumor, and in neuroblastoma. Next, we have oncofetal antigens. So oncofetal antigens, they are normally present in our body during embryonal period, but they reappear in case of certain cancers. Examples for oncofetal antigens are alpha-fetoprotein, that is AFP, which is seen in liver cancer and germ cell tumors, and CEA, that is carcinoembryogenic antigen, seen in colon cancer, pancreatic cancer, lung cancer, and stomach cancer. These are few examples for oncofetal antigens. So coming to two major things, that is alpha-fetoprotein and CEA. Alpha-fetoprotein, it's seen in hepatocellular carcinoma, that is liver cancer, yolk sac tumors. Then it can also be present in a non-cancerous condition like pregnancy. That is, physiological elevation is also possible. Similarly, carcinoembryogenic antigen, it's seen increased or elevated in cancers like colorectal cancer, pancreatic cancer, and lung cancer. So these are the oncofetal proteins. Then we have lineage-specific proteins. So coming to lineage-specific proteins, it means certain proteins which are present in certain lineages. That is, with the nature of the protein, you can identify the lineage of tumor. Example for that is immunoglobulins, which is seen usually associated in multiple myeloma and in gammopathies. Then PSA, prostate-specific antigen, which is seen elevated in prostatic cancer. These are lineage-specific proteins and they help in identification or the diagnosis as well as in monitoring the treatment response. So PSA, as I said, it's elevated in prostatic cancer and it's also elevated in non-cancerous conditions like BPH and prostatitis. Then we have mucins and glycoproteins. So mucins and glycoproteins, they are basically carbohydrate molecules which are elevated in certain cancers. So these are not specific for diagnosis. Example is CA125 in ovarian cancer, CA19.9 pancreatic and colon cancer, and CA15.3 in breast cancer. So CA125, it's a marker of ovarian cancer, but it has chances of false positives. So these false positives can be seen in non-cancerous conditions like endometriosis or PID, that is pelvic inflammatory disease, or in normal menstrual cycles. Okay. Then the final category is cell-free DNA markers. So cell-free DNA markers means DNA fragments which are present in circulation. So other than the tumor cells, these fragments will get released into the circulation. So these specific markers, the DNA markers, can be detected in blood, urine, stool, or sputum, whatever is the sample. Okay. So advantage of the cell-free DNA markers is that you don't need a invasive technique. It's a minimally invasive technique. You can use liquid biopsy like stool test, a blood test, a urine test, sputum test, etc. Then it will help in detecting driver mutations or causative mutations or DNA changes that are associated with cancer. And it helps in early detection and targeted therapy selection. So it basically gives an idea of the DNA nature. No? So it will help us in diagnosing the cancer as well as planning the treatment like targeted therapies. So these are the different types of tumor markers. Now we'll see what is the utility or the need of these tumor markers. So mainly in case of oncology, we can use it in the tumor markers in case of monitoring a particular treatment response. So for example, alpha fetoprotein levels. Alpha fetoprotein, it's a oncofetal protein, right? So the level of AFP, if you monitor that, that will help in monitoring the response to particular treatment. So if AFP levels are dropping post a treatment, then it indicates that the treatment is successful. That is one use to monitor the response. Then another utility of this tumor marker is that it can help in detecting recurrence. Okay? Certain markers, if their levels are increased post-treatment or during the course of treatment, then it can let you know that the treatment is not working properly or the cancer is recurring. So rising level of CEA in case of colorectal cancer is one such marker which we use for knowing the recurrence. Okay. Then we have prognostic indicators. Okay, that is the same thing that you can use the marker to assess the treatment prognosis, how well it is improving, or how the treatment is working and all that. One such example is PSA, prostate specific antigen. So post prostatectomy, if there is high levels of PSA, then it can indicate that there is tumor residual or there is recurrence of tumor. Then these markers can also be used for a screening purpose. That is for diagnostic screening test. That also we can consider certain markers. But CA125 is not a marker considered for screening because there are chances of getting false positive. So these are the 4 basic uses of tumor markers: for monitoring treatment response, for detecting tumor recurrence, then for prognostic indication, and for screening. So it's the tumor markers. From what we have learned so far, we can understand that these are not diagnostic as such. That is, a single tumor marker cannot be used as a diagnostic marker for a tumor. It is always in combination with the histopathology or the clinical correlation that come to a particular diagnosis. It can only be a helpful tool which aids in diagnosis, but it's not a direct diagnostic tool. Okay. So why are tumor markers not primary diagnostic tools? One is because there is lack of specificity. So it can be elevated in conditions other than tumors also. For example, PSA can be increased in a normal BPH or benign prostatic hypertrophy, which is very common in elderly age group. Then it can also be elevated in prostatitis, that is inflammatory condition. So if you see a high PSA level, we cannot say it is a definitive diagnosis for prostatic cancer, right? That's it. There is lack of specificity. Then there is lack of sensitivity. That is, certain cancers may not release certain markers, while certain markers can be released. So it's not sensitive. Sometimes you may have cancer, but markers may not be elevated. That is what is called as sensitivity. So as I said, it is best to use these tumor markers along with radiological imaging and histopathology as well as clinical features for the clinical findings. All these together will help you in the diagnosis. So there are chances of false positive, as I mentioned, that is in benign conditions or non-cancerous conditions. Also, you can find certain markers elevated. One is PSA, seen in BPH and prostatitis. Then CA125, which is elevated in endometriosis and pelvic infections. Then alpha fetoprotein, which is also elevated in liver cirrhosis and viral hepatitis. CEA, which is seen elevated in people who are chronic smokers or in people having inflammatory bowel disease. So these false positive, will affect the specificity. Then there can be false negative also. That is, not all lung cancers will have EGFR mutations, right? EGFR mutation can help you in deciding whether you can give a targeted therapy or not. But it doesn't tell you that, if it is absent, it doesn't mean there is no lung cancer. Similarly, if CA 15.3 is negative, it doesn't mean breast cancer is absent. There are breast cancers which can be CA 15.3 negative. Okay. So our key takeaway from this session must be that tumor markers must be interpreted along with the clinical context, that is, along with the histopathology, along with radiology and the clinical findings. All right, now we'll move on to few question answer discussions, MCQs. So first question, a 55-year-old man with a history of chronic alcohol use presents with weight loss, jaundice, and a liver mass on ultrasound. His serum alpha fetoprotein or AFP is markedly elevated. What's the most likely diagnosis? So before we move on to the options, let's see what is given in the history. It's a 55-year-old man. It's a middle-aged man with chronic alcohol use. It's a alcoholic patient. And what is his presentation? He has weight loss, he has jaundice, as well as on imaging we have found a mass, liver mass. Okay, so this given history, with his habit of alcoholism and weight loss and jaundice, it can lead you to something related to liver, right? Now again, the next finding is that there is a mass on ultrasound. Then again we can we can say it is very likely a liver lesion. And next clue is that the serum alpha fetoprotein level is elevated. So we know that AFP is a oncofetal protein and that is elevated in liver cancer. Now coming to options. The options are metastatic colon cancer, hepatocellular carcinoma, pancreatic adenocarcinoma, and gallbladder carcinoma. So with the given history, if you correlate, most probable answer would be B, right? Hepatocellular carcinoma, which arises from liver, and it's seen as a mass in the radiology. Similarly, AFP can be elevated and these clinical findings can be present. Okay. While colon cancer, it's less likely. Pancreatic adenocarcinoma, yeah, it can have weight loss, jaundice, but liver mass is less likely and AFP levels are usually not elevated. So, answer is hepatocellular carcinoma, and AFP is a tumor marker, especially for hepatocellular carcinoma, especially in people with high risk like chronic alcoholism and people with positive viral markers, that is hepatitis B and hepatitis C positive patients. Okay, hope that's clear. Now we'll move on to next question. Here, there's a 30-year-old male who presents with painless scrotal swelling, and on examination, there's a firm, non-tender testicular mass. Serum HCG is elevated, but alpha fetoprotein is normal, which is the most likely diagnosis. Coming to the options, we have A, seminoma, B, Yorkshire tumor, C, embryonal carcinoma, and D, hepatocellular carcinoma. So from the history, we know that it's a young male, 30-year-old male, and the presentation is a painless swelling. On examination, that is firm, still there is no pain, non-tender, but a testicular mass is seen. And on the biochemical investigations, we have found that beta HCG is elevated and AFP is normal. Okay. So from the history, we can say based on the age and the presentation, it's a painless swelling and the increased marker is beta HCG. So we can come to the diagnosis of seminoma. What are the factors that support it? Seminomas, they usually secrete HCG, but there is no elevation of alpha fetoprotein. And alpha fetoprotein elevation is seen in non-seminomatous tumors like yolk sac tumors. So other options were yolk sac tumor, embryonal carcinoma, and hepatocellular carcinoma. So hepatocellular carcinoma is definitely out of picture because AFP is normal here. It is usually seen elevated in HCC. And similarly, yolk sac tumor also, we said AFP can be elevated. Okay? And from the presentation, it is not at, it's a painless swelling. So it's more likely a seminoma. Okay. Coming to third MCQ. There's a 48-year-old woman who underwent surgery for ovarian cancer and has rising CA-125 level on follow-up. Okay. So what does this indicate? We have four options: A, tumor recurrence; B, benign ovarian cyst; liver cirrhosis; and endometriosis. So here we know it's a patient who had underwent surgery for ovarian cancer and her CA-125 level is increased on follow-up. Right? So from this, I said certain markers, if their level is increasing after treatment, then we can say, no, on follow-up, if it is increasing, it can be a diagnostic, it can be an indication of recurrence. The answer is tumor recurrence. It's a CA-125 elevation is a strong indicator of recurrence. Last MCQ. A 32-year-old woman has a family history of breast cancer. She wants screening but has no symptoms. Which marker would be the most appropriate? CA 15.3, CA 19.9, CEA none. Okay. So here we know that the patient doesn't have any symptoms. She wants to do a screening test and she's very young. She has a family history of cancer. So among these markers, if you look, only one comes specific to breast, right? CA 15.3. And we also know that if CA 15.3 is absent, it doesn't mean that you don't have cancer. So you know it cannot be used as a screening tool for breast cancer. And the rest of the two markers, they are not related to CA 19.9 related to pancreas and CA is also not related to breast. So other two markers are out of picture. So the apt option here would be none. Because if you want to screen for breast cancer, the ideal option is radiology, USG or mammography, and mutation studies like BRCA1 and BRCA2. These tumor markers are not used for screening. So the answer is D, none. That's all for today. Thank you so much.